My topic that I've been looking at over the past 4 weeks is the models of patient access to primary care and how this has changed from the 80s to now, and the role of digitalisation in primary care. So, if we start off with what is patient access, I think it refers to several key elements. So, it includes whether patients can obtain care, how quickly they tend to be seen, how easy it is for them to navigate the system, and whether they can access the adequate information and resources they need to manage their health. So, quite often, primary care is described as being the front door to the healthcare system. It is a lot of patients' first point of contact, and it plays a crucial role in coordinating ongoing care for patients. As time has gone on, the demand on primary care has increased. So notably, kind of it's driven by this concept of an aging population, and with that, a rising number of people who are living with chronic conditions, and as well, there's ongoing workforce pressures across the NHS. So some of the aims of my presentation today is namely kind of to compare access models from the 80s to what it looks like today, explore the role of digitalization a little bit, and also right at the end consider equity and perhaps future implications. So in the 80s, primary care looked very different to kind of what it looks like today. There was this concept of open surgeries. So patients would walk in, would wait to be seen instead of kind of booking appointments in advance. They were more likely to perhaps see the same GP a bit more consistently. So there was the kind of environment allowing a strong relationship to develop, and it provided a perhaps a high level of continuity of care for patients. For some patients, even some patients described the waiting area as some sort of social evening out, as opposed to what it's like today. People would be able to talk and wait around and talk to people who are around them. Um, as well, consultations were almost entirely face to face typically. This would either be in practices themselves or in patients' homes during home visits. And during the time, there was a minimal form of triage system. So patients were usually seen in the order they'd arrived in, typically, apart from maybe those who came in with more urgent kind of presentations. So if we have a look at kind of appointment systems and how they've changed over time, so before the 80s slash in the early 80s, like we said, practices mostly operated this concept of open surgeries. So turning up, waiting to be seen, kind of a first come, first served basis. There wasn't much formal scheduling, as per se. Um, as it time progressed through the 80s and 90s, appointment systems started becoming a bit more common. Patients would book appointments, so they'd either come into the practice and book one, or although telephones weren't too common, some people would still ring in and perhaps book an appointment for themselves. So this kind of introduction of a bit more structure and predictability for practices. And if we look at what access to appointment systems look like today, it is very increasingly digital. So many practices nowadays use online booking systems, they have online triage systems. And on top of that, care is delivered by a wide range of professionals. So you might see a GP, you might see a physician's assistant, you might see an advanced care practitioner, and other perhaps healthcare individuals. Another thing I did look at as well was the concept of out of hours care. And this has changed from kind of the 80s to what it looks like now. So in the 80s, GPs would have on-call rotas where they were kind of personally responsible for their patients for 24 hours perhaps. So often this might have meant being on call overnight, carrying out home visits and emergencies. So there was this strong sense of personal responsibility for patient care. And in 2003, there came a GP contract. So that kind of removed that responsibilities of out of hours care from the individual GP, and this was transferred over to primary care trusts. And if we kind of fast forward a little bit to now, in terms of out of hours care, it's mainly provided through a range of services. So NHS 111, either over the phone or online. We have walk-in centres, we have community pharmacies, minor injury units, and emergency departments, like A&E, that patients can come at during these out of hours cares that GP practice might not be open. So if I move on to the concept of digital transformation, definitely in more recent years, there's a significant change in the transformation digitally in primary care and healthcare overall. So it includes the introduction of remote consultations. We have online booking systems and triage systems, and also the use of the NHS app, which is used to access test results, to order repeat prescriptions, to manage care. It has a number of functions. Um, so quite recently, actually, I believe it was in October, GP practices in England are now required to offer online appointment booking systems. So it gives patients the ability to describe their symptoms and message instead of using phone or in-person contact. And this was done to perhaps free up the phone line to a GP surgery to, I guess, for those patients who might need a bit more urgent care. Um, so, according to the Office for National Statistics as well, more people in England now contact their GP online rather than by phone. And I think this quite reflects that changing pattern in how uh, quite a few patients tend to access their care and how this has changed over time. But despite this kind of shift to digitalization, face-to-face care still is important. So in 2024, around 3 in 5 GP appointments, so quite a bit over half, were still delivered face to face. I think this highlights kind of the importance of kind of maintaining that face-to-face concept in primary care. And overall, it's quite apparent that the use of digital services has grown rapidly. So if we kind of look at some facts from 2021 to 2023 in kind of recent years, NHS app registrations increased from just 2 million to over 30 million in those 2 years. So we can see there's been a massive uptake in these changes that have come about. With changes like this, I think it's very important to be able to consider both the benefits but also the challenges that come alongside this. So, digitalization in primary care offers several important benefits for patients. We have patient convenience. There's easier booking for some patients, perhaps messaging and access to healthcare information, faster access to care, quicker triage, perhaps, and responses, perhaps a quicker way to get an appointment allocated to you, reduce travel time if there are patients who might need fewer in-person visits for things like simple queries or follow-ups. And alongside this, I guess for some patients, it means less time off of work and caring responsibilities that they may have. So this concept of digitalization for appointments can be managed a bit more flexibly around people's lifestyles. However, alongside these benefits, there's also challenges that certain members in community
Elsa,
may face.
enough. No, stop.
Uh,
Enough.
so a major one is digital exclusion. That is quite a big issue. So the concept of a lack of access to perhaps devices, internet or stable connectivity that some patients may have. This also includes perhaps a lack of confidence in using digital tools. There are concerns about a loss of human connection. It is harder to build rapport and trust without face-to-face contact, perhaps for those who might predominantly be having appointments that are either over the phone or over a call. There are also data security and privacy concerns. So this could affect the willingness of patients to engage with digital services because of worries about confidentiality or how their information might be used. And even language and communication barriers where there may be some digital systems that might not provide the adequate support for certain members in our community to be able to fully understand and access digital healthcare. So, whilst digital transformation improves access for many, its benefits aren't evenly distributed across all communities. There are some groups who are better placed to benefit from digital healthcare, and there are others that are at risk of perhaps being left behind in this move. So those who tend to benefit more are those who might be younger or working age adults, those who might be digitally confident, those who live in urban populations even. So for these kind of groups, digital care often offers greater convenience and flexibility for them, perhaps faster access to services. But in contrast, there are those who benefit less from this. So those who might be experiencing social and economic disadvantages in society. So we have communities like asylum seekers and refugees. We have communities like the Gypsy Roma travelers. We have ex-prisoners or current prisoners. We have those who might be homeless, even those who are just less digitally savvy than others. Um, so for these sorts of communities, digital systems that are being introduced can create additional barriers to care and might kind of worsen existing health inequalities they might already face instead of kind of reducing them. So a major question is where do you kind of draw that line? So digitalization has made primary care more efficient and it's made it more convenient for the majority of patients, but access isn't quite universal. So there are some patients, like I said, who lack maybe digital literacy or an access to the devices or a reliable internet. So that creates quite a significant barrier to care for them. But it's important to take into account as well, the other end of the spectrum, there are highly digitally literate patients who could even overuse and strategically navigate digital systems. So, for example, they might repeatedly submit requests or withhold information to try to bypass these online triage systems that are in place. So, it creates this concept of a dual challenge at both ends of the spectrum. So, whilst digitalization improves efficiency and convenience overall for perhaps we could say the majority of the population, it also still risks widening inequalities if these differences between people in access and their ability isn't addressed. So it raises that important question of where do you draw the line between how efficient something is and how equitable something is. So digital healthcare needs to kind of move forward to support the majority without excluding these kind of vulnerable populations or creating unfair access to those who might fall in the gaps. So overall, what does this mean for primary care today and what it looks like today? It's changed a lot since the 1980s. There's been a shift from this concept of perhaps continuity-based care, so where patients might have seen the same GP regularly, to something that's a bit more efficiency-based care, I would say now. It's focused on perhaps quicker access to care and targets. So, on top of that, as well, nowadays patients carry a bit more responsibility for managing their own health and navigating digital systems from the comfort of their own homes, perhaps. But these changes, like I've mentioned, haven't exactly been equal. The access to these varies across different populations. And there are these groups that face these barriers. GP and primary care staff are under increasing pressure as time has gone on. There's higher demand, there are perhaps more complex cases, greater administrative workloads on top. So so over time, this is how I'd say primary care has changed perhaps, and digitalization brings along benefits, but also challenges that are apparent for both patients and staff alike. So if we kind of look ahead, kind of some predictions are we probably will be seeing the concept of artificial intelligence being used in digital triage systems if they're not already. Expansion of multidisciplinary teams are already so vast and diverse, and this wider adoption of the hybrid care model. So this concept of combining both digital and face-to-face services. Moving forward, I think what's needed is digitalization in primary care needs to prioritize inclusion. There is support that is needed for patients who lack perhaps digital access or skills so that they're not excluded from care. So digital and face-to-face services should be effectively integrated. So instead of digital replacing face-to-face, they should be developed side by side, without replacing one another. Ongoing perhaps staff training to keep up with the rapidly changing technology alongside patient education so that there is support for them to be able to confidently use these digital tools that are coming about. And I think finally, kind of the concept of systems and them being designed with equity and accessibility and data security in mind, and even patients actually being involved in shaping services to ensure they meet real needs by perhaps giving feedback or actually being involved. in the actual development of some of these systems. So that is kind of what I have been looking at over the past 4 weeks. These are some of my references. I don't think that's very interesting, but thank you for listening. But also, I just want to say thank you to you guys for being here, for listening. Thanks to Tom, to Jack, to Paul, to Fran, for kind of providing their insight and for guiding me and Ben through the past 4 weeks. But on top of that, a lot of this information, some of it was gathered through doing literature scoping, but a lot of the context for this has been gathered through being able to join in with calls with a wide variety of kind of healthcare professionals and different members of staff, perhaps, that have helped me kind of gain more of an understanding over the past 4 weeks of these issues that I wasn't that aware of prior to starting. So, yeah, thank you. I will stop sharing now.
Thank you, Hannah. Um, I'm going to open it up to questions and any observations, really, for a few minutes worth before we go on to Ben. But my observation is really that this seems to be the digitalization in particular seems to be an extra twist to the inverse care law, because the list of people who you mentioned as being finding it possibly tricky to access healthcare services are the most needy people in our society. So the most needy, once again, get the worst deal. So I'm going to open it up to either observations, or we can have stories if you want, or questions for Hannah. Are you okay to answer questions, Hannah?
Yeah, sure.
Good. Any observations or questions? Paul.
Hannah, thanks ever so much for your presentation. I think you've done ever so well. Well done. Anyway, I what um, I just wanted to ask you about is on one of your overheads, you talked about digitization um, is supposed to increase efficiency. And I just wondered what sort of feedback you had about um, whether the new systems are more efficient, are more effective and more efficient. And the efficiency bit is cost effectiveness, whether it is better to, you know, I mean, what concerns me most is about each problem that people present with tends to be dealt with as a separate problem by a separate practitioner or a separate doctor. And I'm just really concerned that that is actually less efficient in the long run. I just wondered what you thought about this and what you learned from your studies.
So I think one thing is, I guess, off face value and saying it's efficient is one thing. But for example, in a call that I had with um, someone from MedAct who are looking into the Mulberry practice, they'd said the Mulberry practice uses Anima as a booking kind of online system. And I found out that one of the communities they're looking into is like asylum seekers and refugees. For these communities, they would kind of try to use these systems, and it wasn't easy for them to navigate. So for something that should essentially quicken up this concept of access, it wasn't really, if anything, it was just harder for them. And then what they would do is try to ring up the receptionists or the GP surgery, so Mulberry in this case, and then be redirected back to using the app, which kind of led to this circle of them going around. So some of these asylum seekers as well that were trying to access appointments, they would be joined by some of the members of these charities to try to book these to perhaps speed up the process a little bit and help them in terms of communication. But even then, there was this concept of, like you're saying, like it wasn't efficient for something that was introduced to increase efficiency. If anything, it was kind of just that patient going around in circles trying to access their first point of care. Um,
Thank
Yeah,
you.
that's the big paradox, isn't it? That surgery got the contract for looking after asylum seekers, and then were forced. There's no choice for the practice but to use the system that can't be used by the people who they've been given a contract to look after. So complicated, isn't it? Any other observations or questions? Jack?
Again, well done, Hannah. I think you've done fantastically well, and well presented as well. I was wondering whether that you looked at any data about A&E attendance, because there's huge issue, isn't there, about people go to A&E to get their healthcare because they can't access in whatever way their GP or whatever. And of course, that section, the more disadvantaged group of people who struggle with the digitization, are going to perhaps be the people that go down to A&E, and well, it's a huge issue, isn't it?
I personally don't remember facts or figures about, I think, A&E kind of like usage and rates off the top of my head, but I think from kind of reading around and also calls for context, like you've mentioned, these people, so essentially kind of communities who aren't able to then get access for their problems with their GP practice, kind of then their next point of contact is A&E. And I think this is quite a wide known thing in the news. And if you read around, it's quite well known that the waiting times for A&E are horrible. There is the concept of, I guess, corridor care. So if anything, I think this issue of access with perhaps GPs and primary care exacerbates these issues that A&E might face in their waiting times. But that's kind of.
Thanks. Yeah, great. Any other questions at all or observations? Yeah, okay. Yeah, well done, Hannah. Honestly, probably going to say it again after Ben, but definitely I have swapped sides, as it were, now as a user of our services. We need doctors like you, so sooner you qualify, the better, eh?